So, basically, Derek Moore, who is owner and operator of Ortho Bullets, which is the top orthopedic educational system in the world. He's based out of Santa Barbara. What he's been able to accomplish has been nothing less than incredible with Jan and a whole team of professionals. I'm in my office here, by the way. So basically, Derek was so delightful to post out because there's a lot of evidence posted on the website. He posted, his gut instinct. He may have reviewed it critically, but he just said, based on biological rationale, which, Sir Bradford Hicks in the UK 100 years ago said that's number one. So, adding BMP shouldn't increase subsidence. That's probably contrary to what you would expect. Okay? So, what are the problems with this? Well, I outlined them already. More than a third are revision cases for adjacent. So the question basically was this. They basically did a retrospective analysis of what? 100 patients approximately, okay? Which, 100 patient, even a trial, is going to be limited in its ability to produce valid estimates of any outcome, right? So the problems that exist are, you got revision, and we're talking about cervical, I think it's cervical. I'm pretty sure it's cervical posterolateral fusion, I believe. I'll have to look that up again exactly, but it doesn't really matter in terms of the analysis of what they're investigating. Like, there's some technical considerations based on what they're doing. But the bottom line is you have vertebrae you have vertebrae that are coming around, right? And you have discs in between. And this goes for the entire spinal column, right? And we call it a lordosis, basically, depending, versus a kyphosis. Lordosis is when this would be the front and this would be the back. And a kyphosis is when it's shaped the other way, is when you see people with osteoporosis that are like 100 years old, over 85. They have little fractures of their vertebral column and their spine bends and they shorten as well. So basically, presumably, I had to look through the paper more. There's arthritis, and generally arthritis will occur not just at one. You'll get milder arthritis in another area as well. And when they fuse this area, what happens is the adjacent segment gets loaded, okay? And it has been shown to probably advance the arthritic cycle in the adjacent segment, right? We previously published a meta-analysis many years ago on disc versus median area falla, who's a neurosurgeon now down in the United States, on disc replacement versus fusion, and the whole idea of adjacent segment disease, which they mean degenerative arthritis. It's almost like a traumatic event if you fuse the other side almost, but we call it, adjacent level disease, can advance more quickly. So a third of these cases are dealing with adjacent segment disease. Okay, so are they going to respond the same? Second problem is, so do I expect, right, based on that any of the treatments are going to be, is the absolute rate of anything that I see going to be the same for a revision case versus if they're using any of this for the first segment, right? Obviously, the complication rates and the subsidence, all these things would be more likely in this. The treatment effect might be different, and the absolute of any evaluation, odds ratios, anything may be completely different. So aggregating those two, again, is inappropriate in my opinion, although people might argue there's some value. We're already at 5 minutes and we've only got 1 point, by the way. Number two, okay, so they do a retrospective analysis. Now, retrospective analysis for me basically is exploratory by nature. And it makes it the emphasis on the analysis. The question has to be very precise, and you have to have the data. If the data is sloppy, it's gonna be a very difficult or inaccurate. If it's not well collected and all that stuff, big problems with retrospective analyses. If you have decent clinical records, then you got to get it out of there and record it properly, which a lot of times students do, and that's a problem as well. And it makes the analysis really important because you're going to have to start adjusting for this. You might have missing values, very common. How you're going to treat that, oftentimes not even reported at all, how they dealt with that. When people tell me they have retrospective and complete data, I say they're full of shit because they're full of shit. Okay? Right? Unless you're Mo Bandari, I don't know, like Xavier Griffin, Costa, Duckworth, and you say, oh, I got complete data. Well, generally they don't say that, and a lot of them have a plan for the missing data, and if they don't, and they just don't impute or anything, it's clearly outlined in their discussion, their interpretation based on the attrition. Okay, so we're at 7 minutes already. Let's talk about some analytical shit. Okay, sorry for my language. So they decided, okay, if we use this cage, and the cages, they look different, and they talk about the diameters of the cage. They can be titanium, or they can be this radiolucent substance called PEEK. And the argument for PEEK generally is you can see the fusion better with the PEEK implants. Okay, so their endpoint is any subsidence, which means it starts to collapse. And on top of that, they had an afterthought, in my opinion, to stick a biological agent in there called BMP, which they didn't do for this, but they did in these cases. Okay, look at how disjointed that looks already just from, if you're going to cook a cake, this cake looks like shit, right? Okay, the endpoint is subsidence. So, collapse. But then they have 3 types. But they're not going to report all the types, and then, you have none. Okay? They're just going to aggregate them all, like they're all the same, which is crazy. Okay? All right? So, again, I've filled this book up to the max. I've got about tons of these lying around. So we have the cages. All right, let's get down to it. Let's get down to analytics. Okay, so what I would do is, PEEK cage, I've reversed them, I know. And I would say, what's the subsidence rate? 1, 2, 3, and the actual event number and the percentage. They only provide the percentage, so I have to back calculate the number by dividing. That's annoying, okay? And I would do it for both of them. Same for BMP, right? 1, 2, 3. Is this provided? No. Why? No idea. Okay, so this is what I'd expect from, maybe a junior resident, something like this. Okay? At least get this friggin' done. Okay, so then we go on and let's talk about some more advanced stuff. So, all right, now they want to know, like they start saying we're going to adjust. Okay? So we're going to do a multivariable regression, and what we're going to assume, right, is we're going to put in a bunch of variables that might influence the event, that might be more in the peak group than the titanium group, like smoking and all this crap, that might, because smoking inhibits bone healing. And we'll put it in and we'll just, that statistically, we're going to control and take that variation in the outcome, which the outcome is any subsidence at all. All right. Okay, and the B factor is the odds that it pulls out of having any subsidence, right? And the factor would be smoking in this case, yes or no, or the amount, if they wanted to do a linear scale of the amount of cigarettes per day. But they didn't do that, just smoking or not, and that's pretty common. But generally, it wasn't smoking. The main analysis that they said, which I think the BMP was BMP, sorry, I should say cage type, and BMP, right? These are the two factors. Odds ratio, what's the likelihood of having subsidence as you go from 0, no BMP, to BMP. And we're going to control for the cage type, okay? And provide an odds ratio for BMP. This was what Derek's question was, right? Well, the problem is every single person that got BMP was in the peak group. So why would you control for cage type when they're all in the peak group? You can't control for it. You have, so generally what, if you were looking at a quality of life scale, and I did a video on this yesterday, but it was not this, I was kind of on the move, and you were like, okay, I got this peak cage, and there's some variation, and maybe it's higher or lower. I'm just trying to do something like and then you have your titanium cage, and you have differences between them. This one looks the same, okay? Your quality of life score, and this is 1 and 2 group, okay? Whatever, right? Okay, so basically the variation in the outcome that's explained, so this is a continuous dependent outcome of quality of life. Let's just say it's SF36, doesn't matter what it is. Some of this is explained by the cage type. If there was a difference, say titanium had a higher quality of life and it was better than peak, then you'd say that some of the variation in the outcome is pertaining to the cage type, right? And that is supposed to be independent of the BMP effect, which it might not. So in fact, if I was doing this analysis, I'd want these rates, 1, 2, 3, for peak, BMP, no BMP, BMP, no BMP, all of them. And so we're talking 500 plus patients now, at least, so for something this common, right, with no revision cases in it, okay? So we got this variation explained by the cage, okay? But then we have this variation because we have BMP, no BMP, right? And similarly for this one. Now we're going to be up to 15 minutes. So you don't have time to friggin' deal with this, right? No BMP. And so what we're going to say if we're putting in a regression, we have all these groups, and we're assuming that this difference is similar to this difference, is what we're assuming. Now you could aggregate these and make the difference, or you could just take an aggregate of the differences, right? And say, okay, this is from BMP after we remove the variation for the titanium, right? And they got to be independent from each other, okay? The problem is this, okay? So as we go from no BMP to BMP, right? We're following the difference in the outcome. No BMP, there's a variation, or peak to titanium. So essentially, we were going from peak to titanium, right? But all the BMP groups, all BMP patients are in peak. When we go from peak to titanium, and we also go from BMP to no BMP. We also can go from no BMP to no BMP, but there's no there's no titanium with no BMP. So most of the variation, they're both correlated. So as the thing, it's like, okay, if we try to keep it fixed, the cage fixed, how are you going to that's what it does. If we keep it corrected or fixed, how do we move the other variable? You can't. They're correlated 100%. R equals 1. The statistics. So if you look at what it looks like statistically, it's like this, a Venn diagram, right? And so, because they're so correlated, here's the total variation, these two circles, right? And then there's overlapping variation. That's explained because when you move one variable, you move the other one. And it doesn't know which variable is doing the work. It can flip it this way, that way. So BMP might be doing a benefit, and the cage peak type might be worse. It doesn't know what's happening, but if the cage type has an effect, if the BMP has a odds ratio of 1.4, no BMP, 1.4 increasing subsidence, and it would depend on the level of subsidence, but peak is 3 increase, and it attributes most of the problems to the BMP because it's confused, it will reverse this completely to 2.6, 2.7, whatever. There's your explanation. Many times it takes this variation out, and it's very confused and might take it out of the analysis and inflate the p-value. That's the most common way that the program will deal with collinearity, right? And the fact is, we haven't even discussed possibly a couple more things. Well, in the BMP cases, why did they use BMP? That would be in the rationale. Well, were they higher risk cases? So all of a sudden, we're at higher risk, BMP's at a deficit. So we can reduce this number down to, let's say it's 1.7. But the BMP cases are already at higher risk than the non-BMP cases, and all of a sudden we get to, the peak deficit could be 1.7 or even 1.5. And because of this baseline risk difference, you're going to see a difference anyway. And then, boom, no BMP is better. What other ways can you get to it? Okay, well, maybe in the BMP cases, subsidence, they had a ton of type 1 subsidence or type 2. But there was more type 3 subsidence in the non-BMP cases. But you've just done a composite outcome for all subsidence. So actually, you've got a problem because obviously the outcomes arguably are worse in the non-BMP cases, right? You just got a bunch of them up here that you aggregated into a composite outcome. So tell me why this study is useful. Now, if we're going to do interaction analysis, what we do is this. We look at this difference and the variation. It would be similar to this, right? No BMP, BMP. Right? But we'd have little bars on both of them. And we look at this difference and the quality of life, just because a continuous dependent is the easiest way to look at this. And is this difference statistically significant? Now, interaction analysis, Alexei Rito said you need about 16 times, and that's supported in the literature. It can vary. It depends on the data structure. But bottom line is are these differences consistent? Right? You have to test them. And so basically, when you have you're assuming, if you're doing a logistic regression or linear, let's just say this would be a linear regression, but it's a similar concept. You're assuming, like if you're doing marginals, which is basically the proportion that would have subsidence, you're assuming parallel lines, right? Well, it doesn't matter which cage it is. The difference is the same. The difference between BMP and no BMP, right? This would be titanium maybe, or peak, and this would be titanium, whatever, right? This would be titanium, right? But what happens if it looks like this? or like this, then they're not the same. And you need big sample sizes to look for this interaction, these type of things. You can look at it graphically. Again, this could be the percentage subsidence, and you're doing a predicted, and you're putting an interaction term in and seeing what's happened. Or in a linear scale, you're just graphing the scores and you can see it. So 20 minutes versus 2-minute read. There you go.